I'm going to try my best to prepare you to not do that.
So wait, we weren't supposed to fail the other one?
I forgot. They actually did last year too. Well, now you see what my questions are like. So I hope you don't. Let me disconnect and reconnect.
Chapters 3 and 4 today, where we have two knowledge.
Yep. If I get through both, I'm going to have both knowledge assessments due tonight so you can focus on studying for the exam rather than having a bunch of stuff today. Okay. They're both 2 questions. They won't take you very long. All right. Yay, it worked this time. All right, chapter 3 is all about the continuum of care. So when someone first has a diagnosis, disability, injury, whichever that we're treating, what is the traditional route of which their healthcare is going to go, the different settings that we'll work on, the different things that we'll work on in each setting, and we're going to move through those today. We're also going to talk about some not super fun stuff, but things that are important to know about billing and insurance purposes and stuff like that. I give you a brief overview of what insurance is, how it works, the major kinds, Medicare, Medicaid, the different parts of them. But you have to remember that I might say something now, and then at the end of the year, something passes in legislation and it changes completely. Insurance is a moving target. That is something I want you to know about, but it can change very, very quickly, especially when it comes to federal things like or state government like Medicare and Medicaid. All right, let's go to this one here. Let's talk a little bit about documentation. You guys have been introduced into SOAP notes, okay, and then there's different types, narrative notes. There are, there's even checklists that some companies do that build notes for you. Why do you think documentation is so important? It's proof that you did it. This little saying up here, it says, if you didn't document it, it didn't happen. And that's exactly how it is looked at in a legal case. If for any reason you get called in because a patient is suing the company or whichever, the only thing that you have to stand on is your documentation, period. So it's really good to have documentation on your side. Again, if you did not document it and you did not put in your SOAP note or your narrative note, you'd have no leg to stand on. It's your word against theirs. Okay? Documentation should look like a report card does in school. Okay? This should tell us how a patient is doing, some type of activity, or how they perform the intervention that you did. It's kind of like if I read your documentation, I should be able to visualize how the patient did something and not have really any questions about it, okay? I should be able to visualize that client and put into perspective how they're going to be able to perform that intervention again if I did it with them, okay? Here's a question. How could you prove to an insurer that a client is making progress and should continue their therapy if you didn't document it in the client's medical report?
Would they have to just come see it for themselves?
That's kind of a trick question. You can't. You can't prove it to them. If you don't document it, their insurance will not approve more therapy. So if you have a client who you know has an insurance who is traditionally bad for cutting clients from therapy services, Humana is one of the worst. Generally, people really like Humana insurance, but when it comes to therapy, they're one of the first people to cut. They're like 21 days out. I don't care what you got going on. I've seen a lot of people get cut and go home that, are going to be very unsafe. And I have documented. There's nothing I can do. If they say no and they can't afford it out of pocket, we talked about it's a little over 300 some odd bucks a day to stay in a nursing home. I mean, who can't afford that? It's super expensive.
Are they like a Medicaid provider?
Who? Humana, I can't remember what they are. I think they are a managed Medicare, I think. Don't quote me on it. Yeah, I don't know 100%. I just know them by the name Humana. I'm sorry, but I think they're a managed Medicare. Professor Turley might know, because the OTR sometimes has to deal with insurance more than the OTA does. But it's really important too to know, like, traditionally you may have 21 days with a Humana patient, but you have a whole bunch of stuff to work on. At that point, you need to make the decision, what is the most important thing that I can work on with this client to make them as safe as possible when they go home? They might not be able to do a whole bunch of things, but what is the very minimal, the most important thing that I can get done in these 21 days before they get cut, okay? All right, so let's talk about the effect of reimbursement. I'm going to talk a lot about these different types today, but this is the biggest or the most I'm going to probably talk about insurance throughout your entire year with us, okay? Reimbursement, your book's going to define that for you. It refers to the payment of the healthcare provider for a service. This is how we're going to get paid. This is how they're going to define it for you guys. This is what is the reimbursement for this service. There's different reimbursement for OT services in different settings. The Center for Medical Services, CMS, is these people that kind of manage these insurances, right? They're going to help to, hey, this is beneficial, this is not, this is how much you get paid for, this is not. Medicare Advantage insurance is like Medicare Part C. Okay, you're going to hear it called Medicare Part C a lot. Overall, Medicare is the largest payer for therapy services across the country. Medicare Part A people, Medicare Part B, and there's several different. I'm gonna go over those in a second. But when someone has Medicare, those are kind of considered gold standard patients. A lot of people like those. Facilities will fight over getting Medicare patients. They actually do have people that go into hospitals and recruit patients to come to their facility or to their home health company or whichever. And they actually, with social workers, because that's normally the people who are going to decide, or help them anyway, decide which company or which facility or whichever they're going to go to. They'll have these recruiters. They'll go in and bring them these nice little things to sit on their desks or buy them lunch and say, hey, just wanted to remember Genesis when you're sending patients out. It's kind of a weird system, but that really is how it works. I don't know if you would call that a patient benefit or not. Sometimes if patients don't know, they don't have a preference where they go, they don't really know the facility. So it's really important too to make sure that in your own personal circumstances, that if you have a family member that's going to go to a facility and they ask you, what is your opinion? Would you try to have one in your mind that you've researched, you've looked up, you kind of know a little bit about? Is the therapy team great? Ask people. Word of mouth spreads really, really fast in West Virginia. So, finding out, hey, did you have a good experience? Did you have a bad experience? Stuff like that is very important. So anyway, Medicare, let's see, Medicare Part C. Let's talk about that one first, and I'll back up. This covers almost everything that the government-run Medicare system does, but it also has dental, hearing, and some drug coverage. Yep. Yeah, this is Part C still. It's a little outlier here. That's why I wanted to talk about it first. With just the Part C one? So Medicare Part C, it covers pretty much everything that Medicare does, Medicare Part A, but it also has dental, hearing, and some drug coverage. It's kind of just an expansion of Part A. All right, so back to Part A. This is the main one. This one is the insurance that covers hospital stays, home health, skilled nursing facilities, or SNFs. You'll hear us call that a lot, SNF, SNFs, and hospice care. It's Part A. Part B covers your medical costs like ambulance, durable medical equipment or DME, prevention, mental health, and some prescription. Okay. Part D covers prescriptions. That one's the drug. You remember it? Part D, drugs. Okay. Medicare also, like I said, is the highest payer for payer source for occupational therapy, but it has a dollar limit amount on how much the person can actually have, and that changes often. So I'm not even going to try to tell you what the amount is because it changes every year, sometimes monthly. It really just depends what Washington says. However, there was a great big change that happened across the scale for therapy. I don't know if Professor Turley has mentioned it in any of her classes yet, but it was PDPM or PDGM. This is the patient-driven payment model. Patient-driven payment model. This is the new thing. This is the biggest change in insurance payer in a long time for OT. So what that did is more or less, to simplify it down so you can understand it really well, is that they said, okay, this is this patient. They have this diagnosis, this diagnosis, this diagnosis. They're coming from a hospital or they're coming from, home. They were referred to a skilled nursing facility. Okay, they put all this information into a formula and out pops a number. That number is the amount of money that that patient is going to get for therapy services across the board. It is for OT, it is for PT, it is for speech. That's it. That's what they're getting. Okay? Now, if you gain a diagnosis, that can change, but this is the amount of money that they're going to get. What happens then is the company gets this amount of money, and they get to decide how much therapy this person is going to get in order to, not go over budget and make a profit. Right? Because that's what it is. It's still a business. They still have to make money. They have to keep the business running, right? So in theory, it was, okay, this person is going to get as much therapy as they need, right? We're going to give you this amount of money, but we're not going to limit the amount of visits or all this that they get from the government aspect of it, right? What ended up happening was, okay, the government's not going to say you get this many visits. Now the company will say you get this many visits. So you may be over here as the OT or the OTA saying, listen, they need 30 visits in order for me to reach these goals. And so, well, in order for us to make a profit, and they have PT and they have speech and they have all this other stuff, well, we're going to give you 8 visits. Get what you can in 8 visits. That's what has happened. That is how this payment-driven model has come out. Now, I was leaving the field or leaving practicing full-time whenever this really went into swing. Professor Turley, do you have, in your experience, is there any outlier to what I just said that you found with that payment-driven model? That's pretty much it, right, in a nutshell.
And it's very outcomes based.
Mm-hmm.
If they kind of look at it like if this person has a diagnosis of CDA, they had a stroke, then that goes into the consideration of how much your stroke patient visits will get. If all the other stroke patients kind of averaged out that they had 6 visits, then yours needs 6 visits.
Yeah.
Whether or not your individual may actually need a lot more than that.
Right. And then sometimes your company has the right to say, okay, we know we're not going to get reimbursed for this, but if the patient needs it, do it. And a couple companies tried that at the beginning, but it's a business like any other that, they give this amount of money. How much therapy can we give them for this money and still make a profit? So I know in my company that I work for now, they were like that too. It hit with home health, except they didn't, or they gave them the amount of money and we said, okay, they need this many visits. They said, well, we're going to have to split those across all this. In order to make a profit, this is how much we have to stay under. Eventually, every now and again, you can say, listen, I don't care. This person needs, and sometimes they'll give you leeway, but most of the time they're like, listen, you got to discharge them. It is what it is. It sucks. It was a good thought in theory, but I think it's more of a blame shifting kind of thing, because now the government's not saying, I'm not limiting your therapy. I'm just giving you this amount of money for it. Do what you can with it, right? And the business is like, well, I can only do this amount for it. So it's kind of switched blames in my head, but it sucks. All right, Medicaid. Medicaid is the state program for insurance. This is reserved for people with limited income or circumstances. A lot more people got Medicaid coverage when the pandemic hit. It expanded it a lot. That's all starting to rein in a little bit. They decided there's a lot of money going into Medicaid right now and not a whole lot going back in. But it's kind of that. I'm going to give you an example here that it blew my mind when I first got into the field. We had a guy who had Medicaid coverage who we had all documented across all therapy, all disciplines, that he was ready to go home. He did not need our services. And this is when I worked at a skilled nursing facility. They legally cannot push him out of the facility because abandonment. So he gets to stay there. As long as he abides by the rules, they don't have a reason to kick him out. He gets to stay there more or less rent-free, 3 meals a day, and paid for by the Medicaid system. And he's ready to go home. He completely worked the system to his benefit. It was crazy. Now, he ended up getting kicked out a couple months later because he went out in a taxi to a liquor store, brought a bottle of liquor back to the skilled nursing facility, and was offering shots to the residents.
Sounds like a guy.
So it blew my mind, and that's what got him kicked out. But, they're even not restricted to where they're allowed to go in a skilled nursing facility either. That's where they live. So they're able to go in and out and do kind of what they want to. And that's the thing with Medicaid, is there's no limit on how much that they're allowed to have either. It's kind of, with me and Medicaid and skilled nursing facilities, it was never a question of they're going to get cut. They are not going to get cut. So. All right, let's talk about the VA system. The VA is the big provider of health care for veterans. Then you have an outlier called TRICARE, which is just a little bit different because it provides health care for for active duty members and their families. Okay? So TRICARE is more or less an expansion of VA healthcare, but it includes active duty service members and their families. Is another insurance that I had a lot of good experiences working with. When I was on my field work, I did it at a VA hospital in Beckley, and they never got turned down for anything that they needed. I never had a single patient I worked with. If they needed equipment, a lot of times they could go 2 floors up, pick it up that day, and leave with it, and it was covered. I've heard a lot of good things, a lot of bad things. In my personal experience, I didn't see hardly any negatives to the VA healthcare system in therapy aspect. If they needed it, they got it, more or less. They even some qualify. There's a certain level of disability from the veteran's perspective that they'll even give them money to reconstruct their bathrooms and have a contractor come in and remodel and make it handicap accessible. There's a lot of cool things that the VA has that you don't have in a lot of other settings. Then you have workers' comp. This provides wage replacement medical benefits for those who are injured on a work-related accident. That varies state to state. But this is the employers are actually paying into this system in case something happened. And then lastly, you have private pay, and that's just out of pocket. You're just paying it from your own wallet, which gets very, 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 very expensive. I don't know many people who can afford to do that. All right, cool, awesome. All right, we're going to start talking about the continuum of care. Is there any questions left on the insurance aspect? You're going to want to know those for the exam. You're going to know those. What they cover, the different expansions like TRICARE, what does Part D cover, stuff like that. I might give you a scenario that says so-and-so has this insurance in this facility. What might you do with this patient? What might their insurance cover? Okay? What's up?
The VA includes the family also, or just
That's
the
TRICARE.
member?
TRICARE.
So if they're not active, just a service member.
It's VA care.
Okay.
So VA and TRICARE are two different. TRICARE is just an extension of VA that includes active service members and their families.
Okay.
So my dad is retired reserve right now, and I'm VA.
Right.
So
So the VA serves the family also, or just the? Sorry, I'm confused.
TRICARE serves the families.
Even if they're not active.
Right.
yes.
Okay.
Right. TRICARE is the family insurance regardless. But active duty members aren't VA, they're TRICARE as well. When they're not active, they're VA. Got me?
Yeah.
Okay, cool. Any other questions? Good? Cool. All right, so let's talk about the continuum of care. You have acute settings. Acute meaning that it can last as little as 1 day, or it could be as much as months, but it's a short term. Think of acute as a short term, okay? This requires daily monitoring by a physician. And the main goal here is to stabilize the client and discharge them out to another setting. The reason that is such a big goal is because it's really freaking expensive, acute care for therapy services and everything else you're getting. I'm going to go into what you're going to typically see in this setting. There's a lot of stuff, but post-acute is there must be access to a physician as needed, but they don't need to be on site. And the services for this might be at home or in the community. Okay, this is pretty much everything outside of a hospital, more or less. But we're going to break them down. There's several that we break them down into, and these can be very, very quick. You can literally go from one to the next, to the next, to the next within a week, or even less in just a few days. Okay? All right, let's break down the first one. You're going to try to fill out this the best you can as I go down. If you miss one, some of them, it can vary a lot. So don't worry if you don't get every box covered. Just try to get a brief overview as you go through, okay? All right, so the first one we're going to talk about is acute hospital. Oftentimes, OT, PT, and speech are going to be like the first responders with rehab there. They're going to be the ones right up in front with this client. This is somebody who has probably had been in an accident or had a massive injury like a stroke or massive heart attack or things like that. There's a huge variety because, as you can tell, there are all different ages, diagnosis, and acuity levels. All that stuff is just all over the place in a hospital, right? Your prior, I'm going to write this down. I can't use the board yet. PLOF, okay? This is a huge word or a huge acronym in OT. It's prior level of function. You want to break down OT into the smallest nutshell you can. It can be therapy to try to get them back to their prior level of function. Insurances love those words. This very simply means is where were they at before the injury, before the accident, before the trauma, whichever, where were they at before treatment? Okay, that's the goal to get them back to. Now, this very well could mean that they're not independent. What was their prior level of function? Were they needing men assist with putting on their shirt before they had a stroke? And now they're dependent. So our goal is to get them back to men assist. What was their level prior to them starting occupational therapy services? It does not mean independent. It means where were they at before you started seeing them? Okay? Cool. Another big goal here is to make sure that they're safe and stable enough to discharge them to the next location. wherever it may be. I'll talk about where, in a perfect world, what that continuum looks like. Your treatment in this situation is very much geared towards the next discharge location. Are they going to be from this acute care hospital setting? Are they going to be in a subacute? I'm going to talk about those in a second, but are they going to be there? Are they going to be in a long-term care? Are they going home right after the hospital? What is the next plan? Okay, that's what our goals are wrapped around. We need to be able to get them ready for that. If there's a huge change in someone's health, like let's say if someone had a stroke and then you're in there in the acute hospital setting and you're working with them and you notice more stroke-like symptoms or they're getting worse, after notifying the nurse or the person in charge on that floor, whichever, you always have to talk to your OT. That is a massive change in their healthcare, and you can no longer provide services until the OTR has done another evaluation. Okay? If there is a massive change, now it doesn't mean you go in and they're having a bad day. Okay, I need to stop till the OT sees them again. That's different. This is a massive change in their health. This is the setting that it's very, very common to see that multidisciplinary team that we talked about, where you have nurses, doctors, speech, social work, everybody in there. Okay? Any question on the hospital? All right. Next, we have the acute rehab. This is the rehab facility inside of the hospital. Okay, so you're not really working with the client as much in their bed, but kind of 50-50. Okay, so in the acute hospital, you're pretty much working with them in their rooms, doing very basic stuff. When you discharge or go to the acute rehab portion of it, your stuff changes a little bit. Again, the client population can vary a lot. This one's going to be really hard to come up with treatment for these people. You're not going to go in normally and just say, okay, we're going to do dressing today or bathing. You're going to have to really think outside of the box of treatment, because these patients are probably going to have IVs and catheters, monitors, all this stuff hooked up to them still. So you're going to have to really think outside the box when it comes to treatment, what is safe. To be honest with you, if I were to be thrown into an acute setting, I would have to do some research too. It's a little bit different world of OT in those settings. It's not your typical long-term care home health patient. These are people that are still pretty critically ill. Okay.
It's a lot of getting them bed mobility.
Yeah.
So that they can start progressing in their functional mobility so they are ready for rehab.
Yeah.
So you're getting them edge of bed.
Yeah. Your highest level of people will maybe make it down to the gym, but most of the time this is going to be still. It really depends on the client. I don't want to say all the time or not. It just really depends on the person. This is normally about a 3 to 5 day. Okay, as far as therapy goes, statistics, this is about 3 to 5 day stay. That's again because it's extremely expensive, because they have a lot of stuff going on. It's very, very, very expensive. And insurances are like, get them out, move them to the next part, because the further they go down, normally the cheaper it is. I think that's actually true, isn't it? From acute all the way down to like outpatient, it gets cheaper as the line goes through, doesn't it?
I think so, but it's also been shown that if you can move someone on through, usually outcomes are better.
Mm-hmm. Yeah.
Alternate outcomes are better.
Yeah, you don't want somebody laying in a hospital bed and you just kind of doing range of motion on them while they're on a ventilator or something, right? That's been a big part of OT in COVID treatment, and OTs that are working in hospitals is doing range of motion and bed positioning and stuff like that with patients who are on ventilators, because they, it's the same thing if you're sitting there and you're not moving your joints at all. those joints will start to lock up and get very, very tight and very, very painful when you move it. So just the very simply moving all the joints through a normal range of motion several times a day is a massive benefit to the patient. Massive benefit. OT has become more respected, I guess, in COVID times. OT and PT both. People aren't just thinking, wow, this is actually very beneficial. I worked with a COVID patient that I forget how he described it. I think he called it, they angel winged him. Is that what it was? Airplaned him out when he was, because they just didn't know. And they thought, keeping his hands out, keeping his chest open, he was on a ventilator with COVID, that it would help. And I mean, it saved his, he's alive, and I worked with him, but he had a really bad shoulder injury afterward because he was extended out for so long. It was a brachial plexus injury, wasn't it? Yeah. So he had all kinds of problems with his right hand after that, and didn't have anything going in, but it was because they had poor bed positioning with him. At that point, they were more worried about saving his life, but now he also has something he has to deal with for the rest of his life. So they didn't actually, and I even asked, they never even had him work with an OT in the hospital. I was the first therapist that was treating him, and he was at home. So his wife was a PTA. Pretty weird. Here's what it is. All right, long-term acute care. These are the people that are going to have to be in the hospital because of being medically unstable or whichever for longer periods of time. The patient population, again, it varies a lot. These are more fragile. Again, the primary goal here is moving them to the next point in their rehab, but medical stability, safety, things like that are very important in this stage. I want you to learn this word. I called it the gold standard of all OT goals because it's so wide open. You can do anything at all with a patient, and it falls under this. And it's called activity tolerance. It's my favorite goal. I love it when I see it on an evaluation because it literally means you can do darn near anything, and it will help them increase their activity tolerance. Okay? This is goals you normally see with patients that are extremely low level, hard to get them to work with you, or they're just not ready for a lot of rehab. Okay? Activity tolerance. So if I ask you on an exam, what is the gold standard of occupational therapy goals? Will tell me activity tolerance, to increase activity tolerance. Okay? Cool. Again, like I said, I'm kind of skipping over the primary sources of reimbursement because those can change, but there's a little box there on each of these slides that tells you what they are. And I want to touch on this one about the documentation. What type of documentation do you think you might see in this setting? Is it very extensive documentation? Is it going to be shorter? Any type of note you think is pertaining to this setting that's like this is what you would use? Isaiah's got this one. Is it very strenuous documentation? Do you think? Would you want to be a document very, very well in this setting?
Yeah.
Okay.
They're in a critical state.
Okay.
Or close to it, so
Okay.
I feel like a lot of more liability and risk involved.
Okay.
So you want to have your tracks covered to make sure like it doesn't happen to you.
I would agree with you, but I'm also going to say that was a trick question. That's true in every setting. That documentation should be strenuous in every setting. It should never be an easy note to write. If you find yourself writing an easy note, like, wow, this is flying through it, now you'll get your little, quirks and stuff about documentation that helps you do it faster. But if you're putting the same thing down and it's not, individualized and stuff, documentation should be something that's a little bit time consuming, okay, from the therapist perspective. It should be, you want to paint a very clear picture, especially in this setting too, though. I would agree with you that these are critically ill patients and a lot of liability here. Very good. Any questions so far? The last two and this one, they kind of blend together. And even on your knowledge assessment, I put them as the same choice because this is very quick. It's hard to distinguish between these three, and I don't make you distinguish against these three, okay? All right. Subacute rehab. Again, it's a little bit less intense. They're not as critically ill here. This is someone who's medically stable. The primary goal here is going to be the same as the last, more or less. It's going to be restore functional independence or prior level of function. The treatment strategies here are very similar to the one we just talked about a second ago. Not a whole lot of changes. This is more or less just a step down in acute care, okay? All right, now we're going to move to one that's a little different. The long-term care people. What do you think are some age groups that you might see in long-term care? This is your, when you think of it, of a Genesis facility, or they could be in a long-term care floor in a hospital. Just because someone's at a hospital doesn't mean that they're in acute care. A lot of them have long-term care floors, where they're going to need to be in the hospital for 60, 100 days, and they're going to need to rehab this whole time.
Francis Hospital here in Charleston, long-term acute care.
Doesn't CAMC does too, don't they? General, I think General has the long-term care floor.
I'm not familiar with that one.
I'm pretty sure they do.
I know that
They have one of the coolest therapy gyms I've ever been in too. These patients are going to need 24-hour assistance. One of the main goals or primary goals here is going to be increasing their independence with ADLs, and then getting them familiar with operating and using a wheelchair. Okay, some typical treatment strategies: ADL activities, endurance and strengthening, cognition. This is where treatment's starting to open up. It's becoming more, what you traditionally think of as OT. And then CPT codes. Do you remember the documentation assignment we went over together? Remember how we had the DSM codes and all that stuff? Does anybody remember what CPT codes were? What were those for? The billing, right. But it's the therapy codes. It's your treatment codes. This is where you're going to start seeing those come into play. The Therax, the Therac, remember that? Yeah. Documentation here is going to be pretty much per session or weekly updates. I always, regardless if the company or whichever setting, if they want, even if they don't require it, I write a note on every patient after every single session, no matter what they say. Because I think if I'm going to go in front of a judge and have to defend what I did to somebody, I want my note to back me up because I know the company's not going to, right? Okay. Any questions on that one? Cool. So this is what you need to think of too is the like Genesis facilities. These are long-term care places, okay? All right, moving through the continuum again. Home health. This is my personal favorite. This is what I do now. Client population is all ages. Gosh, I've seen a bunch of people. The youngest I've ever treated was 18, but they have some pediatrics as well in home health. Your primary goal here is going to be ADLs and IDLs in their natural context, meaning instead of just simulating something in a rehab facility or a gym, you're actually working with they have in their home, in their environment. I love home health. I think home health is very true to OT. I think it's about as true OT as you can get because you're working with them and their situations on their goals. It's all about them. Very holistic. Now you're not just looking at the patient in a holistic perspective. You're taking into account their actual environment, using their stuff. I try not to take a lot of equipment in with me in home health. I try to use things that they have. If I'm going to have them do a strengthening exercise or a dressing exercise, I want them to use their shirt, or I'll use a gallon of milk, or depending on the patient, maybe even a water bottle if it's light strengthening. Something that's theirs. Okay. And I'll even make a home exercise program around stuff that's in their house. Use this for this. Do this many times a day. Stuff like that. Primary sources of reimbursement. You don't need to know a whole lot about this, but you have what's called an OASIS. This is what's called a start of care for therapy services or services in home health in general. This was a big change. When COVID hit, OTs fought for a long time to be able to do OASIS and then these start of cares. And it wasn't until COVID that the Trump administration opened that up. And now OTs are able to do that. It was a huge change and opened up a lot of job opportunities for in the OT careers. All right, and then lastly, what kind of documentation is done? I don't agree at all. Your book, this is what it says, but I do daily notes no matter what period it is. I do it all the time. It's changing a little bit, but for your exam purposes, know it as progress or skilled maintenance notes. Okay. Yeah, another way to think about those is they'll ask you to do a weekly note of their progress rather than doing one every day. I do one regardless, every day, every time I see them. No. There's not going to be. Because I don't agree. All right. All right, so let's move on through. The next one is outpatient. Again, the client population can be all over the place. These are the places like Dynamic Physical Therapy down in Canal City. These are.
That was the name of the class. This morning in class, I had a complete brain.
Yeah.
Whatever, I couldn't think. Dynamic.
Yeah, Dynamic. Outpatient too can be in a hospital. They have outpatient clinics a lot in hospitals, but most of the time you think about it, they're freestanding places. If you've been in South Charleston, First Settlement Physical Therapy is a big one. Outpatient is the patient's coming to you like a doctor's visit, like a scheduled visit.
How he works it.
Yeah, what you work at as outpatient?
Where do I work?
No, that's where you work now, right?
Yes.
Is an outpatient clinic. Yeah. The primary goal here is to restore function, gain independence. They're going to use a lot of modalities in this setting, the ultrasounds, e-stims, that kind of stuff, orthotics. We do that in a lot of settings, but outpatient does a lot. Medicare, this is a setting where Medicaid's kind of limited on what they pay for. Personal insurance is huge. Workers' comp. Workers' comp is really big in outpatient. A lot of people go to outpatient settings for work injuries. A lot of them have work simulation areas just for those claims. All right. And lastly, the last one that we're going to talk about is hospice. You can think about hospice and OT, right? I've got a video that will show you how occupational therapy works in hospice care, but without reading the slide, what might we do in a hospice setting? We're all about gaining function. These are people that are not going to gain function. These are people that are getting ready to pass away, traditionally thinking. Comforting who? The family. Yep. What else? Yep, bed positioning is a big one. Pain management. through ways of, joint mobility, orthotic training. If someone, putting their hand in a certain position to make it feel better, so it's not as painful, stuff like that. Payment on that's a little bit different, but normally it's through Medicare, private pays, and then documentation that just kind of depends on the setting. All right, do you guys have your books? Yeah, go to page 51. In the bottom right-hand corner, that's the continuum of care. That's what the perfect model should look like, okay? So they go from acute care or acute hospital to long-term care, inpatient rehab, skilled nursing, home health, outpatient. In a perfect world, that little continuum right there is what it would look like, okay? Now, I've had a lot of people as of recent that will go straight from a hospital to their house after having a stroke and be like paralyzed or have weakness on the right side. And I'm like, why didn't you go to a facility? Like, what the heck? A Health South, or Encompass, I guess it is now, these really tough, stringent, exercise-driven places that have really, really good results. Why didn't you go there? Normally it's insurance or they didn't know about it. COVID has a big impact on that right now too. They have any kind of outbreak, they stop taking patients. And their main goal at Encompass is to kick you out. That's their main goal. They want you there and then kick you right out. Normally, you don't see patients in there longer than 21 days. Some they will keep longer if it's a massive stroke or whatever. But 21 days is pushing it with Encompass. It is really, really tough therapy. Instead of you having it for a couple hours a day, they're like, your job today is therapy, and they'll put you through like 8 hours of therapy. It's pretty intense. They have really, really good outcomes though. All right. Some different healthcare advances. We've gone from volume-based thinking to a value-based. This is that outcome stuff that Professor Shirley was talking about a second ago. Rather than how many people can we push through, what's the value, how great are the outcomes that they're getting. Wellness and prevention. Prevention therapy is something that is we weren't allowed to bill for a long time, but now we are. We're helping treat or keep things from happening. They realize, wow, if we can stop them from falling and breaking their hip, it's a lot cheaper than treating them for a broken hip. So, those kind of things are now allowed. They weren't for a long time. The different payment systems, again, is single payer, pay for performance, Medicare, high deductibles, all this different stuff pays into how much therapy that they're going to get and how much the insurance is going to, get. A single payer means they only have one insurance, but they can have multiple insurances, like different parts of Medicare, or they have private and Medicare. They have a bunch of stuff. Pay for performance is outcome driven. Managed care can be a little bit difficult to deal with too. Those are like I said, the Humanas of the world that are. Professor Turley, is Humana Medicare managed? Is that what they are?
Yeah.
Okay, yeah, that's what it was. They're a managed Medicare, and they're really stringent on documentation and kicking people out. So good documentation with those notes. I've had a couple notes of my own that we sent it to the billing department. They're like, nah, you need to say that better, and they'll send it back, and then you redocument. They really pick apart managed care notes. And then high deductibles, those go pay into it too. How much do they have a huge deductible they have to pay before their insurance helps out? All right, we're almost there, and we're going to take a break. Some technology in healthcare is electronic health records. That's the majority of companies now. Everybody's working on a tablet or on their computer. Point of service documentation is huge with companies because it saves productivity. Sitting there actually working with the client and documenting as you go. Genesis is huge on that. I don't think many companies are against that, but it's really big. Telehealth services, you're now allowed to do that. Got opened up with COVID too. People are providing OT services on Zoom with patients. It's pretty crazy. I hated it. I did for like a very short amount of time. I tried it. I was like, I don't like this. But in certain settings, pediatrics, they do a lot of education with the family and stuff. So I can see it working with that. I personally didn't care for telehealth, but it's wide open field right now. A lot of people are doing it. You can actually be in West Virginia and work for a telehealth company in another state as long as you're licensed in that state and provide services from here. It's pretty crazy. I've seen several job openings for stuff like that. PRN, telehealth therapists. OTs can do evaluations on a Zoom call. There was a lot of things that I never thought I would see that happened with COVID. I had OTAs that were kind of, I don't even know if this was legal, but they were kind of doing evaluations. They would have the OT on FaceTime on a tablet and set it up in the corner of the room, and they would kind of walk through an evaluation with the patient, the OTA would, and the OT would document it. I didn't even know, to me, I was like, that doesn't even seem legal, but they did it a lot. That they didn't want therapists.
As long as it's written up by the OT can
Yep.
do the interpretation of the
All right.
letter and writing it up and signing it.
It just was, it seemed so crazy. I mean, I knew this therapist really well. I was like, you're doing what? That's crazy. But they didn't want, they had one OTR that covered 3 facilities. And with COVID, they didn't want her going in between facilities. So she worked from home from her computer, and her OTAs did her evaluations with her on FaceTime, and she documented it all. It was pretty crazy. So different collaboration in healthcare. We got, this is the last slide, and then we're going to take a break. It's become more coordinated care for the holistic perspective. People are becoming more aware that it takes more than just one therapist to be a good team. And it's a big partnership with me, the physician, client, family, and I've meant to put on there to like everyone in the healthcare team. And then the bundled payment, that's the lump sum payment per episode of care. That's what we're in now. That's that PDPM, PDGM stuff, okay? All right, here's your knowledge assessment. You have 2 questions on this chapter. By the end of this chapter, you should be able to answer these questions. You have a 47-year-old with end-stage AIDS, a 35-year-old recovering from a wrist fracture, a 54-year-old with a recent severe head injury, happened last night, 89-year-old with severe Parkinson's disease, and a 72-year-old with pneumonia. What setting might you see these clients in? This is traditional. I know that you guys are going to say, well, I could see them in any. Yes, you could. What traditionally would you see this in? Okay? Got me? If you think about it, this is not a very hard question to work through. Okay? Here's your second question. Match the setting with a client who had a CVA. What activity would you do in each of these settings? This is traditional. Okay, remember I talked down your therapy changes as you go down in that continuum. You have cooking a meal, dressing and bathing, washing their face in bed, and being fitted for a high-tech orthotic device. What setting might you see that treatment intervention in traditionally? Okay? No questions?
We're like answering
Each one of them goes with one. Yep.
What, do you want us to describe why
No, because I'm giving you 2. You don't have to write a blurb about it. Just tell me what your answer is, but make sure the question's in there. Okay? All right, cool. All right, let me stop this recording.